I'm pleased to introduce our guest this evening, Dr. Heidi Prather. Dr. Prather is an attending physiatrist at Hospital for Special Surgery. She specializes in sports medicine and the diagnosis and non-surgical treatment of spine and hip disorders and conditions. Dr. Prather received her doctorate of osteopathic medicine from the University of Health Sciences College of Osteopathic Medicine. And following medical school, she completed a physical medicine and rehabilitation residency at Northwestern University Feinberg School of Medicine. Dr. Prather has authored many peer-reviewed articles, review articles, and book chapters, and teaches nationally on topics related to sports, spine, and musculoskeletal medicine. Her clinical and research interests include the lifestyle medicine approach to care for musculoskeletal conditions, with a special interest in gender differences, pre-arthritic hip disorders, and their relationship to the pelvic girdle and lumbar spine disorders. I couldn't think of a better person at HSS to give this talk this evening. So I am pleased to turn over the stage to Dr. Prather. We're so glad to have you here this evening.
Great. Well, thanks for having me, and thanks for joining us on a night. This must mean you're interested in health if you're willing to stay up after work or after a long day to listen to this. So hopefully we'll give you some inspiration tonight, either for yourself or a family member or a friend. My disclosures, I'm paid by the PM&R Journal, which is a journal for scientific publications within my own field, and my non-financial disclosures are here. So what about lifestyle medicine? What is this stuff we're talking about, and why is it so crucial in time right now? Well, we are at a chronic disease epidemic, particularly in the United States. A lot of it's based on poor diet, because it's linked to the leading cause of death and disability. Top killers related to lifestyle behaviors include heart disease, stroke, diabetes, and some forms of cancer. And more than half of US adults have at least one of these conditions: heart disease, cancer, chronic lung disease, stroke, Alzheimer's, diabetes, and chronic kidney disease. And they're all related to our lifestyle. Why now too are we talking about this? Well, we have an unsustainable economic situation. Our healthcare spending is somewhere around $3.3 trillion, which is about over $10,000 per person, and 18% of our US gross domestic product. By 2050, Medicaid and Medicare alone will account for 20% of the gross domestic product. So we are spending tons of money on our healthcare, and 90% of that is spent on chronic disease. By 2030, well, my slides are going without me, guys, sorry. By 2030, the number of people with 3 or more conditions is expected to increase to 83 million and cost us over $42 trillion. And employers will have to foot a hefty part of this bill. So what is lifestyle medicine? Well, lifestyle medicine is the use of evidence-based medicine using lifestyle therapeutic interventions such as whole food, plant predominant diet, regular physical exercise, restorative sleep management, avoiding risky substances, positive social connections, and managing stress. And it's delivered in a cohesive way, and it's evidence-based. Clinicians have to seek extra training in this in order to have a full understanding of all the evidence and a format in which to present it. So I have gone on, and I am now a diplomat or I'm board certified in lifestyle medicine as a physical medicine and rehabilitation specialist. It's validated. It addresses the root cause of disease. So we're not just adding a pill to treat the symptom of the disease. We're trying to go to the root cause of the disease. It's been shown to have better outcomes and lower costs than some of the passive interventions such as medications and procedures, and it's value-based care. Engaging, affordable, and it's patient-centered, and it's going towards healing. So it's simple, powerful therapy, and it's based on these 6 pillars: nutrition, sleep, exercise, avoiding risky substances, stress management, and the importance of building and maintaining positive social connections. What I mean by that is relationships that help you maintain a lifestyle that's healthy. So what do we know about lifestyle medicine and successes? Well, most of it's in the world of internal medicine and general medicine. So we know lifestyle medicine in this graph that the top blue marker on the graph here is those who received a placebo in trying to prevent type 2 diabetes. The one in the middle, the red line, is the number of people that went on to have diabetes that took the most common medication we use to treat that, which is metformin. And the green line is those who adopted a lifestyle medicine approach to treating prediabetes and never went on to develop diabetes. So you can see that 58% of reduction in the incidence of turning from prediabetes to diabetes happened in people who took on a lifestyle related approach, which was better than the medication that's typically prescribed. What do we know about lifestyle medicine and cardiovascular disease? Well, kind of seeing is believing. The picture here on the left side is showing a narrowed cardiac vessel in someone's heart that's full of plaques. And they compared that group of folks who had a stent placed to those who underwent a lifestyle medicine approach, which was a specific diet, managing stress, and improving sleep habits. And it showed that the lifestyle approach actually helped reverse the narrowing in the vasculature at follow-up in a year later. So again, these are sustainable effects, they're measurable effects, and it has a great instigation of how it can be applied to other heart conditions. What do we know about lifestyle medicine and high blood pressure? We know meaningful blood pressure reduction can arise from the confluence of lifestyle interventions. That means increasing physical activity, eating better, restricting, getting rid of tobacco, restricting sodium, limiting alcohol. Collectively, those things lower blood pressure outside of a medication alone. So again, these are the three leading things that have really helped develop the evidence behind lifestyle medicine. What does it help about our mental health or our cognitive health? Well, we know adopting a multi-component interventions of lifestyle medicine, including diet, physical activity, and social interactions, has been shown to stave off cognitive decline in aging in at-risk individuals. So people who have a tendency or a family history, you may have that gene pool that may be more likely to go towards dementia and or Alzheimer's. Lifestyle factors can really make an impact on expressing that gene and maybe modifying your risk of attaining that later in life. So but I'm at HSS, and I thought we were talking about arthritis and back problems and things with our musculoskeletal health, our bones, our joints, our spine, our muscles. How is this all linked to back pain or joint pain? Well, half of the adults over 65 or older have arthritis in our country, and 2/3 of the adults are overweight or obese. That means less than 1/3 of us are of normal weight in the United States. Yet 1% of adults have an ideal diet. And this is by the American Cardiology Association's assessment and research study. So remember that 1%. Anxiety is the #1 adult mental illness in our country, and only 1/3 of them are treated. 20% of people still smoke in our country. So we have these lifestyle related problems. We also know that there's a big impact of our mental health, and we're even more aware of it now after the pandemic or during the pandemic. That green line in the middle is sciatic pain. And the blue line, the solid line above, is suicide incidents. So there's this parallel between chronic musculoskeletal pain conditions and mental distress to the point of despair. We know patients with functional disability are 2 times more likely to actually die of despair. And there's a relationship between them. What are we in for after the COVID pandemic? Well, this is a study that looked at, if you look at the bottom graph there, United States adults reporting anxiety and depression symptoms before the pandemic in January to June of 2019, it was around 11%. By December of 2020, it was 42%. My guess that the next survey that'll come out, may be even higher. So we've got to come to some awareness of how our mental health is affecting our physical health, and we've got to start intertwining the care. We spend tons of money on this, over 281 billion in costs for joint pain and arthritis. And by 2030, there'll be more than 4.4 million total joint extremity procedures that will be performed at a hefty cost. 147 billion costs are associated with people that are overweight or obese. That's just the cost of healthcare because of what being overweight or obese adds to the healthcare system. But here's that 1% again. If we change just 1% of the decline of that anticipated trajectory that we're on for increased obesity, we could drop our costs by 84.9 billion by 2030. So even small impacts could save us tons of money and reach a number of people. 42 billion a year is spent on anxiety disorders, and about half of that is spent on people who come and see me for pain complaints. So again, we've got to start marrying what our physical health and our mental health together because they do coexist and affect each other. So what are some of the behavioral links with osteoarthritis, which is wear and tear type of arthritis, or the arthritis that's most common and associated, unfortunately, with aging? So we know 20% of people who have osteoarthritis have symptoms of depression or anxiety, and we know anxiety and fear avoidance beliefs are associated with worse function in patients with arthritis. And depression and anxiety are associated with inflammation. And what we mean by that is systemic in your system inflammation, not just inflammation localized to that joint. What do we know about type 2 diabetes and metabolic syndrome in patients with osteoarthritis? So people who have inflammatory processes it's associated with an increased progression, meaning the OA progresses worse in folks with those problems. We know modifiable lifestyle risk factors also increase osteoarthritis, including having obesity, being diabetic, or having high blood pressure. You're more likely to have osteoarthritis, and you're more likely to have severe osteoarthritis. In fact, people with type 2 diabetes are more likely to have bilateral knee and hip arthritis, and they're more likely to have a greater progression of that. Metabolic syndrome, which is a combination of high blood pressure, type 2 diabetes, obesity, and cardiovascular disease, a combination of those is called metabolic syndrome. Folks with that syndrome are more frequently to have osteoarthritis. And we know folks with osteoarthritis are more likely to have cardiovascular events. So what do we know about lifestyle factors and how tobacco and alcohol are associated with them? Well, we know the relationship between pain and smoking. And again, people who smoke often report higher levels of pain. And once they're ex-smokers, that tendency tends to go down. So the act of smoking has an increased perception of pain and therefore reporting of more pain. The relationship of alcohol and osteoarthritis is a little mixed, but there is a consensus that chronic and high levels of alcohol use tend to result in more severe and more proliferative, meaning in multiple joints will have arthritis. So how do we pull this together? What we're talking about, how these unhealthy lifestyles seems to be associated. Well, how does that happen in our body? Well, it's through these 4 things over here in this left box: an unhealthy diet, a sedentary lifestyle, high stress, and even some medications. Those lead to microbiome dysbiosis, which is the bugs in your gut become uneven. There's good and there's bad bugs, microbiome in your gut. When they become unevenly distributed and unbalanced, we call it dysbiosis. This also results in oxidative stress and cell injury. So actually injury at the cell level. The 3 of those together combined result in chronic inflammation. We mean inflammation in our system, which leads to obesity, type 2 diabetes, cardiovascular disease, some cancers, and depression, anxiety. This was published in a journal in 2018. And I, Heidi, would like to add on the orthopedic side or the musculoskeletal condition side, the same thing is happening. When you have osteoarthritis or musculoskeletal condition, spine conditions, and even chronic pain syndromes are also associated with chronic inflammation. And many of the people that I see with these musculoskeletal conditions have these comorbidities. One's really looking towards the treatment of or longevity, and one's really focused on morbidity. So I've proposed to lead this here in the United States as a musculoskeletal practitioner, that we've really got to start thinking about these things in common, because we know folks with musculoskeletal pain problems develop an inability to move. They have pain-related fears. they stop moving, gain weight, become disabled, and anxiety and depression fits in. And there's an inflammation, they're rooted in inflammation. The same roots that hypertension, cardiovascular disease, hyperlipidemia, type 2 diabetes, and some cancers have as well. So they're married in the same or rooted in the same conditions. We know lifestyle medicine improves these chronic lifestyle related diseases like high blood pressure, cardiovascular disease, hyperlipidemia, and type 2 diabetes and obesity. We also know the approach to this improves the musculoskeletal condition. So we need to start thinking about treatment interventions that can do that. So how do we reduce this systemic, meaning in our body, general body inflammation? And how do we get from there to here, right? Well, the road is not so straightforward and obvious. So let's talk a little bit about nutrition. So what is the gut microbiome? Again, this is good. It's a collective pool of microorganisms. 38 trillion of them live in our gut. And it's fundamental to our health, way beyond just digestion. It helps our immune system, metabolism, our hormone balance, and even our genetic coding. What influences it? Sleep, exercise, toxins, some of our habits, stress, and diet. All of those things affect our microbiome. So what are some foods that actually promote good gut health and the balance of these microbes? Whole foods, meaning the whole food, not the part of the food, right? The whole food. Blueberry juice, that's a processed food. The blueberry is a whole food. And that's where some of our messaging has gone awry, in our society. So whole foods, fruits, vegetables, intact grains, legumes, nuts, tea, coffee, and even dark chocolate. Thank goodness that's on the list. A whole food plant predominant diet fosters the growth of anti-inflammatory bacteria. And there's these substances called short chain fatty acids are produced when certain microbiomes metabolize fiber. So the fiber is the key component of the whole food. When the food is broken down or processed, the fiber is not there. Fiber is the key. It's the key because the short chain fatty acids are produced, and those help us work towards a gut promotion or gut health promotion. Each fiber we consume produces a mixed number of these short chain fatty acids, and they are the dominant driver of our gut health. So the whole food's important because of the fiber. The fiber lends itself to the short chain fatty acid. Short chain fatty acid is what helps us balance our gut microbiome. So foods that can harm our microbiome, okay, just go the opposite of that. So animal foods such as meat, poultry, fish, and eggs. The processed foods, that will do it as well. Excessive sugar or added sugars, added oils can do that, particularly some oils are even worse than others. And any of these foods can lead to a diminished number of those anti-inflammatory microbes and allows for the growth of the pro-inflammatory microbe. So now if you've got the inflammatory guys out there, those are the ones that are going to precede us into poor health. And unfortunately, this is part of our standard American diet. We have over 6% processed food, 6% whole food based food, 63% processed food, and 25% animal-based food. So we've got our plate wrong in what we're eating, which is leading us down this path of chronic disease. What is gut dysbiosis associated with? We talked about the lifestyle-related disease, also associated with allergies, progression of aging, Alzheimer's, multiple sclerosis, metabolic syndrome, liver disease, some cancers, and autoimmune disease. So there's many, many, many things that are related to our gut health that improving our gut health helps us either avoid or better deal with. So again, gut health and body weight, there's a balance there. The consumption of high-fat food induces the growth of bacteria that support fat deposition. So pro-inflammatory, those inflammatory microbes in our gut can cause elevated thing called ghrelin. Ghrelin secretion leads to bigger appetites. So if I have a pro-inflammatory microbe, it emits this substance ghrelin, which then makes me want to eat more. So it becomes this vicious cycle. Microbes influence energy utilization from diet and influence our host genes that regulate our energy expenditure and storage. And our microbiome composition is not fixed and can be influenced by several dietary components. So if we look at what are some calorie dense foods versus various food groups, over here way on the left, you'll see the fruits and the vegetables and starchy vegetables, and way over on the right, as far as density of calories per serving, is going to be your nuts, seeds, butters, and oils. Your sugars and your processed grains are there in the middle. So it kind of gives you an idea of where that is. And what does 480 calories look like? Well, 4 tablespoons of oil versus a plate full of fruits and vegetables. So oftentimes when people start to move into eating more of a plant predominant diet, they're overwhelmed by how much they need to eat every day, which is kind of backwards to what we know of, and especially in the US in the form of the term diet. We kind of think of diet as restriction. And when you eat more in the whole food, plant predominant or venue, you're going to be more likely to actually have to consume more foods than less foods. So there's some misnomers out there with language. So whole food plant predominant diet is a dietary lifestyle that emphasizes the intake of the whole food and minimizes the intake of processed and animal derived food. That is different than vegan. Vegan is a lifestyle that emphasizes the elimination of animal proteins and does not take into account the health food benefits of food. And what do we mean by that? Well, a vegan diet could be the chocolate cupcake with a Dorito, right? If it doesn't have dairy in it and it doesn't have a meat, but it's all processed. And the cupcake and the Dorito are not going to promote my health. Whereas a whole food plant-based diet would be more the strawberries, my dessert, and the grains and the vegetables as part of my main course. That is going to promote my health. So we may go to a restaurant, they know you're trying to eliminate certain things, but it doesn't mean that it's healthy. So being aware of that's important. And then being assessed, the other thing to be aware of is just the risky alcohol use. Alcohol is the third leading modifiable factor that increases cancer risk behind cigarette smoking and excess body weight. Drinking alcohol can increase cancer risk regardless of the type of alcohol you're drinking, and there's really no safe amount. The recommendations is that women have no more than 3 drinks in a day, and men more than 7, and then and then modifying that over time per week. So 14 for men in a week and 7 for women in a week. Again, these are just also understanding what a standardized measurement of alcohol is important as well, because they're obviously not all equal. So we need to start thinking about thinking about how we eat, from pizza brain to whole food plant predominant brain, because that can really help with our health. And when our gut works well, we know our brain works well. People think, and that these two are very intertwined, not only with our mental health, but with our physical health. So going back to these things musculoskeletal disorders are rooted in the same thing, in inflammation. And we know that a lifestyle medicine program can help folks with musculoskeletal conditions. How do we apply that? Well, I've been fortunate to found 2 programs that are based in musculoskeletal medicine and lifestyle medicine. And I've been recruited to HSS to start one here, and we have one going, and I'm very, very proud of it. It's been a lot of hard work, and it's hard work because you're trying to deliver healthcare in a different way. So we have an intensive lifestyle medicine program at HSS, and it's for people with musculoskeletal conditions and lifestyle-related chronic diseases. It's an intensive program, and what we mean by that is there's a start and a finish, and we're trying to deliver an immersion of this in that time frame based on someone's goals and their own schedule. The patients in the program direct their own program goals. So for some folks, they're trying to manage their back pain better. They're trying to manage their knee and their hip pain better related to osteoarthritis. I have some people that are trying to qualify or have better health going into a knee replacement or hip replacement. We have some people who can't even qualify for a joint replacement because of their chronic lifestyle related disease. And so we're trying to optimize them so they can qualify for what can be, quite a life-changing procedure for them. We have an interprofessional team, includes a dietitian, a health coach, a physical therapist, exercise physiology, smoking cessation, and then dry needling and medical massage to be adjuncts for pain care outside of usual medicine or interventions. We have individualized programming in this program, but we also have group programming, which is really phenomenal. And I love doing because I get to spend an hour or 20 minutes with folks talking about just sleep. That's not something I can do in a regular office visit. So I find it very life-changing as a healthcare provider to be able to do that. One of the unique things I've developed out of this program too is that in our program, we have an interprofessional team meeting about patients that are in the program once a month. And the purpose of that is to make sure the team is giving the same language and messaging to the patient, but also to help problem solve. We also learn from each other from the different disciplines. So I learned something from the physical therapist learned something from me or the health coach. And together we're a real team trying to help promote health in the patient. So that patient feels like they've got a support system and a safety net that's there to help them through making big lifestyle changes. So this is kind of an algorithm of what the program looks like. So patients referred into the program, we do a very extensive risk assessment and screening, both metabolic health. So we look at labs, blood pressure, weight. We look at physical activity levels, sleep quality, and how many hours you sleep, what's your stress level like, how do you problem solve, do you have connections, social connections that will support you in this path of change. But one of the most important things we really talk about is where are you on the willingness and confidence in making a change. And everybody can be in a different place. And so we try to adapt our programming based on that. In the intensive program, you're then enrolled, we set goals, and then we develop an individualized program of which different professionals you might work with. So some people's team might be the life coach, the dietitian alone, and other people may have a team of practitioners that includes a physical therapist, the dietitian, maybe they come to me for dry needling. It's very individualized based on the patient's goals. Again, we have our team meetings once a month. We have group programming. Right now we're doing it about one to two times a month, and we go through the different pillars of lifestyle medicine. And then people graduate for the program once they're at the time of meeting their goal. We're working on developing long-term curriculum so that people that are engaged in the program can come back and get those that extra help they may need in maintaining the changes they've had over time. And a lot of this we deliver virtually, so which has been one of the great things of the pandemic as we've escalated or accelerated our ability to do that. We can do things in person, but we can do it both ways, so it's wonderful. So why do we know this works? So I've actually published on it, and this is data out of the first program I started, which is at Washington University in St. Louis. And we showed in our first very small group of patients that went through the program, 81% of them completed the program and 62% of them achieved their goals. One of the big things we noticed in the outcomes was people's anxiety scores went down. And when anxiety scores go down, self-management goes up. I mean, you get in the driver's seat and you're controlling the problem and managing it. It's not managing you. This up the box up at the top is talking about how many times people saw one of the professionals in the group, and on average, if they worked with a specialist, they saw them three to four times during their time in the intensive program. So we didn't overutilize services, but coordinating the services was really important. And this is just a diagram of all the different chronic diseases people in the program had. So they had cardiovascular problems, anxiety, depression, endocrine problems, obviously obesity. And so we had a large smattering of things that people had, and we were able to handle it in a method of delivery like this. So we've now started the program at HSS, and this is one of our case examples of someone who's gone through the program right now. We had a 65-year-old female who came and entered the program because she needed to optimize her health prior to undergoing a total knee replacement. Her health risks included she had class 3 obesity, which is based on, the classes are based on the level of your BMI. So she had a BMI of 42.8. She was pre-diabetic and didn't know it. Part of our screening when she came into the program discovered she was pre-diabetic. She also did not know she was vitamin D deficient. We discovered that on our intake screening. So it was nice. We picked up two things that we thought we could, help her with right away. Her knee pain really precluded her from doing any kind of physical activity. I mean, she was trying to qualify for a knee replacement here. So it's kind of obvious that physical activity would be down, but she really couldn't do anything. And our average pain On a scale of 0 being no pain to 10 being the worst pain ever, her average pain was a 7. So it kind of goes into why she had a sedentary lifestyle and why she had trouble managing her obesity, and also why she was now found to be pre-diabetic. So her goals that she set for herself, that we set together, were to lose 10% of her body weight, was to reduce her hemoglobin A1C, which is a lab measure of how well controlled her sugar is. And that's the one that was elevated that told us she was pre-diabetic, was to improve her vitamin D level. And we know that's important, especially in orthopedic or musculoskeletal conditions, because bone health or quality of bone is linked to vitamin D. We're going to hopefully increase her physical activity level if we could get that pain level down some, and again, reduce her pain. So those were the goals for her for the program. So she entered the program and she had one-on-one visits with the dietitian. She had 4 of those. She met with the physical therapist and she met with the health coach. She attended the group visit regarding nutrition, and she was in the program for a total of 8 weeks. Her outcomes were she lost 22 pounds. So she did lose a little bit more than 10% of her body weight. Her hemoglobin A1C normalized, which meant she was no longer pre-diabetic. She had a normal vitamin D because we addressed that when she entered the program. Amazingly, she was up to 100 minutes cumulative of physical activity per week. She went from 0 to 100. Now, she still needs her knee replacement. She still has a bad knee, but she was able to increase her physical activity while her pain score went down to an average of 2 out of 10. So this is just an example of what, if we can pull things together for people and organize it and have them in a supportive system, wow, the changes she made towards better health. What the patient told us was she thought that changing what she ate and not how much she ate was the key to her weight loss success. And she plans to adopt that for the long term. Music to my ears. That's why I'm in this game in the first place. We want to do this now, but can we get it to where it's something you take on lifelong? She said she was impressed with the process of the program, the ease of getting what she needed. Again, that's having a team around you. So a team approach is really important. And she felt surrounded by a support system that enabled her to meet her goals. And she would highly recommend this program to friends and patients that need this type of care. So again, we're hoping we're providing a solution or a mechanism to a solution for people with coexisting conditions. So what do I have to worry about as somebody to help directing this program? Well, we know when people make big lifestyle changes, we go through these phases. So pre-contemplation is, I haven't really thought about it. I don't think about my weight being related to my knee pain. To contemplating, yeah, I think my knee pain and my weight might be related, or my knee pain and my diabetes might be related. Then I start thinking about it. I need to be more active. I'll go buy some running shoes, but I haven't actually walked out the door in them, but I'm preparing to do that. When people move into that action stage, that's when they really can do quite well in a lifestyle related program. But as a practitioner, we all know that there's relapse associated with this. There's stress, there's family, there's social, there's all types of pressures that can kind of get us back in a path of not such a healthy lifestyle. So as a leader of this program, we have to be prepared for that. And we have to have extra programming for people outside the program or after they graduated that we're hoping to develop so that HSS program can always be a resource for members who have participated and can come back to. Likely most of that will be in a webinar or hybrid a discussion group type sessions. So these are kind of our long-term visions where we're trying to get people healthy, but we want to be a part of maintaining health over time. So again, the lifestyle medicine, the social connectedness is really super important. I can't wait to get back into real life group settings. And we're hoping to do that hybrid. So people who are near our facility can come in person if they choose. And those that aren't or don't want to be, in a crowd yet can attend hybrid via online. Right now, we're still online. But as a practitioner, I've been in practice I'm in my 29th year of practice. These are vital to me. I feel healthier. I feel as if this is life-changing for me when I get to do these group sessions, because I get to interact and give out all the information I wish I had time to in an individual visit. So it's a win-win on both sides, both for the provider trying to disseminate the information, but also provides an environment of safety for people to ask questions because everybody in the group is really headed towards the same goal. So again, the lifestyle medicine program at HSS, we're trying to prevent, treat, and reverse lifestyle-related chronic diseases by applying the 6 pillars of lifestyle medicine in an intensive program. We're here to help you move better and feel better. And again, the program is really directed by the patient, and we design it to meet the patient's individual goals. So thank you. That's what I have for the presentation. I was hoping maybe we can have some real discussion and questions that you might have about this topic.
Thank you so much, Dr. Prather. That was absolutely illuminating all of the information that you shared. We do have one question, and please do feel free to submit your questions to the Q&A. I think that the way you presented this pilot program that you're running seems so successful, and someone is wondering, how does one enter the program? Is it possible? And what are the potential costs associated? Is it covered by insurance?
Yeah, those are great questions. So I'm guessing, Claudia, you'll give us the phone number, which we can put in the chat, which is 212-774-7653. We happens to be my office because I'm in charge of getting this up and going, and my office staff can help you manage your way into an initial evaluation. So usually it's sitting down right now. It's sitting down with me personally to go through what are your goals and why you think you would benefit from a program like this. And we can talk through what your goals are and what you're interested in. You hit the nail on the head there with the money part, right? Our healthcare system, part of the reason I did this is that, I've been a musculoskeletal practitioner for, like I said, 29 years. I've worked in big academic centers, and I got really frustrated. I'm paid well to do passive things to patients. And at some point in time, you feel like you're in sick care, not in healthcare anymore. And when I got introduced to lifestyle medicine, I started to put the pieces together, how this would directly apply to musculoskeletal health. And I have been very supported nationally in trying to get this effort out. And HSS is such a leader in musculoskeletal health. They've invited me to HSS to try to do it here. You may know that the New York City Mayor's office has now endorsed lifestyle medicine as something that all of New York healthcare systems should engage in. And we had our first kickoff meeting of that endorsement, an educational event about 2 weeks ago. And I was chosen as one of the 3 presenters. So we're on the map, and the pressure of the need for this is what may get us to a place where we can get more of it covered. So that was a long-winded introduction, and the answer is it's fee for service. And as you know, your insurance company typically will pay for a visit with a doctor, and typically will pay for a visit with a physical therapist. So those are like usual things. The healthcare coach right now in our pilot program is just a part of the program, so you're not paying an extra expense for that. I'm sad to report that in the United States, though 2/3 of our country is overweight or obese, and 2/3 of our country is diabetic or pre-diabetic, 1/3 of which don't know they are, that many of us, including government payers, do not pay for a dietitian unless you have diabetes or renal disease. Isn't that crazy? Some dietitians in the Midwest, where I came from, the starting salary of a dietitian was $18.70 an hour. And our healthcare system is not covering that. Crazy. So the long-winded answer is if you have healthcare insurance for dietitian, obviously we try to bill for it. Otherwise, it's out-of-pocket cash. Physical therapy is regular insurance, like we talked about. The health coach we talked about. Smoking cessation is a part of the program, so that's not an additional cost other than a routine outpatient visits. So the biggies are, is the dietitian out of pocket. Our exercise kinesiology has developed an online program that's affordable. And then we're starting to roll that out in October. So I'm super excited about that because most places don't have the expertise of exercise kinesiologists. And so I'm really hoping to leverage the value of that with this program.
Yeah,
Okay.
I mean,
Claudia.
I think you did.
Sorry, that was
I
so long-winded.
No, I think it's important because there's so many factors that go into lifestyle medicine. It's not just you're going to visit an endocrinologist, let's say
Right.
you're looking at multiple providers. And I think that's a really
Right.
good point.
And thanks for bringing up, Claudia. You know what I failed to mention is I have a partner in crime in the program who is an obesity specialist, obesity management specialist and internist, Dr. Carolyn Andrew. And she's, again, the value HSS places on that because they have people like the two of us here. And so folks that need additional help and may want to start with medicine and then move over into diet only, we have that.
Mhm.
And again, I think that's something extremely unique about our program because we have the ability to private. And again, she is typically paid for by health insurance. The one thing about the group programming is we have some webinars, but we've gone to group medical visits. And so that's a copay. Again, your health insurance covers that. But if I do it with the dietitian, it's been kind of a workaround for some folks who can't afford the full blown cost of what it takes to cover the cost of a dietitian's hour time one-on-one. And so I hate to say fudging a little bit about how to get the information to people because costs are prohibitive. But one of the reasons I'm at HSS is HSS is very interested in doing this with their employees. And if I can help employees get better, we're self-insured and we can work towards showing cost benefit, which gets us to a sustainable model. And that's why I'm in this game, because some of the neediest people don't have access to this type of care, and we've got to change that.
Absolutely. And I think it just shows, your commitment and the testament to the incredible work that you're doing. A couple quick other questions. Do you need to be in New York to participate in our program at HSS?
I can do telehealth personally, New Jersey, Connecticut, New York, Illinois, Missouri.
Okay, good to know. And if you have any questions about a specific state, if you're watching now, please do feel free to reach out to us. And is the program open just to people with specific conditions or to anyone? Can you have lupus and fibromyalgia, or do you need to be preparing for a joint replacement? What kind of patients are you looking at?
Take all comers. I talked about a joint replacement patient because that's top of mind at a hospital named Hospital for Special Surgery because we got a lot of surgical patients with needs. But the HSS is committed that this is for any patient with a musculoskeletal condition. And so it's just trying to marry those two things together. So no, we're not restrictive on diagnosis.
And I have one more question, if you don't mind. I think it's important. The question, I won't read the whole thing, but it references weaning off of opioids. And is that something that the lifestyle medicine program addresses?
Yeah, thanks for asking that. So there's a website called the American College of Lifestyle Medicine. That's the organization that board certifies and is organizing this. And they've grown from, I think it was 400 people 10 years ago. They're almost over 10,000 members now. So this is a movement that's happening, thank goodness. But if you go there, and you don't have to be a member, but if you go to their website, they have a story page, and you'll see on the story page, a thing from Washington University. It's the first program I started, and it highlights a woman who got off narcotics. And so she was a patient of mine for over a decade and had multiple comorbidities. Some were not lifestyle related, some were. And she went all in with me. This was right when I was in the beginning of learning, and what the heck do I do? And how do I do it? And where do I get more training and blah, blah, all those things that I don't know about. But I was so tired of her suffering. And she said to me one day, she's sitting there with a neck collar on and she's in a wheelchair and she can't move and her knee is swollen. I've been looking at her swollen knee for a decade. And she's thanking me. And I'm thinking, for what? I have not helped you. And then I said, do you want to try this diet thing? I don't know if it'll work, but I'm reading about it. And she did. And she said, I won't quit. And in 3 months of changing, kind of immersing herself into changing her lifestyle, she was off the narcotics. So yes, And I've got partners at HSS who, we have pain management partners who are very interested in helping, tailor the opioid
Mhm, mhm.
reduction over time. So there, again, all the resources at HSS can really help us with that.
Yeah, and I know how committed HSS is to that cause as well. Um, well, we are at time. Dr. Prather, thank you so much for providing all of this incredible information and your expertise and services to HSS and our community. It truly is a phenomenal program that you're working on, and we're so grateful to learn from you this evening. I think especially that case study that you provided and an additional one that you just provided just speaks for themselves, truly. So thank you so much for presenting this evening, and thank you all for attending. We hope to see you back soon.